Good evening. My name is Lemoyne Bennett, and I'm here to talk to you about my intervention that is web-based and evidence-based for depression. Depression is suffered from adults 18 and up, and it is often the cause of major hospitalizations or rehospitalizations. According to healthypeople.gov, 6.5% of the adults aged 18 years and over experienced a major depressive episode in 2008 nationally. The target is 5.8%, which will mark a 10% improvement. Locally, the percentage of people here in Alabama 18 years of older who experienced a major depressive episode from 2012 to 2015 was 6.3%. My intervention is based on Gordon's functional health patterns model. The reason why I went with that because I wanted to assess the whole person. Because when presenting intervention, we tend to treat just symptoms. We don't treat the whole person. We don't understand what the person is going through socioeconomically. What kind of support system do they have? Can these people read past the third grade level? We don't really try to figure these things out. And what happens is people become non-compliant because no one is really understanding who they are as a person. They're just trying to treat a disease, so to speak. With my intervention, like I said before, my intervention is web-based. I want to make it available for computers, laptops, and phones. It will provide contact information to the nearest psychologists, social workers, pharmacies, support groups. Whatever they need is right at their fingertips. And because it's web-based and you can view it on your phone or computer, it'll be a major relief for people in rural communities to have this access or this information at their fingertips. The methods used to come up with this intervention, I did some research on Deep Dive, CINAH, PsycInfo, and all these studies had to be qualitative, quantitative, or RCT. That were no older than 2014, basically, and they had to provide at least level 1 through 3 evidence. And with this, I'm able to present my case for my intervention. And with this, I'm hoping, to, like I said, provide this for everyone, and hopefully I can provide it free of charge. That's what my take is. I think what has happened is we learned how to treat something but not support the actual disease. And this is just some of my spiel, but carrying on, the outcome measures based on my intervention, what we would do is start gathering our patients immediately, like being able to take a week, 7 days, clinic visits, I should say, and get people to volunteer, and make sure that their information is safe. And what we would do after that first 7 days, once we got people to volunteer, we'd teach them about the intervention and have them, go with it, and then reassess our information every 7 days. And then at that 30-day mark, we will follow up with that patient with all the information they provided us through the month to see if it was a success or not. And then we would find out what we needed to do at that 30-day mark to help that patient be successful with their depression going forward. And when that patient came back in, we would use the PHQ-9 to reassess their level of depression and compare it to day 1 to day 30. And The implications and conclusions for this intervention and for this proposal, I should say, is needed due to the ineffectiveness of traditional treatment of depression. Like I said before, and I said through this communication I'm having with you right now, is all we do is give medication. We provide some therapies, but we're not connected, and depression doesn't have a time period where it shows up. It doesn't show up at 12 a.m. or 3 p.m. I feel that this intervention is needed for patients everywhere, so they can have the ease of support right at their fingertips. Thanks for listening. Have a good evening.